Good evening. Oh, whoa, hey. Good evening, everybody. Thank you all for being here. I think we'll start, I guess, now. I just want to introduce myself. My name is Sanjay Reddy. I'm one of the surgical oncologists here at the center in the Department of Surgery. I'd like to just first start by taking a moment to honor all that we've lost with cancer. Please join me in a moment of silence. Moment of silence. Thank you. I'd like to thank our exhibitors today. To start, we couldn't have done this without their support and their help. And I'm going to go through some of the exhibitors now. Our video exhibitor is Exelexis. Our gold exhibitors are AstraZeneca, Caris, Eisai, Exact Science, Foundation Medicine, Natera, Pfizer, and Tempus. And our silver exhibitors, Bristol Myers Squibb, Endeavor, Genentech, Insight, Ipsen, and Teo Oncology. Thank you guys for supporting us and helping us today. I'd also like to make a special thank you to the Colorectal Cancer Alliance Group for being here tonight and their partnership in the community. Very helpful. Thank you, guys. I'd like to just start off with a few words. This is my time now to talk for a little bit, which I never get to do this up here. I'm usually over there, so I'm going to take my time. This is a really special event, and again, I introduced myself in the beginning. I'm an associate professor in the Department of Surgery. I'm also one of the co-leaders of our Pancreatic Institute and our fellowship program coordinator, director. I also sort of took over a role this year as the GI service line lead alongside Dr. Efrat Dotan as a translational piece, and it gives me a unique perspective into this event tonight, where we're really focusing on highlighting the GI service line in terms of multiple different types of cancers. GI cancers is a nebulous term because there's a lot of things within GI. But what we've learned is that a lot of the things and the treatments that we do in this space oftentimes correlate and transcend one another. I've been here now for 10 years, and I've seen this Together Facing event across multiple sort of disease sites grow. And one thing that I've seen is that the focus oftentimes is what you guys and patients see as cutting-edge care and how things have changed over time. And the unique aspect of this group will be we'll sort of see how this transcends across multiple disease spaces. I'd like to spend a few minutes just to outline how the event will run, because it'll be a little bit different this year. We've traditionally held these lecture series in silos, and we've had pancreatic cancer, esophageal cancer, gastric cancer, colorectal cancer, liver cancer. And what we've learned is that cancer blurs lines, right? A lot of the times, these diseases do cross one another. And a lot of the times, the medical oncology, the surgical oncology, the radiation oncology pieces are all involved in treating this disease, in treating these GI cancers. But the backbone is the multidisciplinary care, right? The backbone is the group of people that we see here. It's not just the clinicians, it's also the ancillary support, like the social services, the nutritional support, et cetera. We put together this amazing panel of people today who are going to introduce themselves shortly. And a lot of us are leaders in the field, sitting on National Comprehensive Cancer Network guidelines, part of ASCO, the SSO for surgery, the AGA for GI. And you'll hear today a lot of the information from the providers on these specific disease sites. Once we make the introductory remarks, we'll talk more about the breakout rooms and the sessions that we're going to have this year that's going to be a little bit different than years past. This will include gastric and esophageal, colorectal, and liver cancers. These disease sites were carefully selected because, again, there's a lot of overlap within these disease sites. And you'll have the opportunity to ask these providers everything that you want to know about the disease, treatments, new treatments, things that we're doing that are, again, cutting edge, and clinical trial information as well. I truly believe it's this holistic care for people that separates Fox Chase from a lot of other cancer centers in the area. This collegial synergy you see amongst the team members here is something special. And I look forward to the evening and seeing how this works tonight. And obviously, if there's any questions, please feel free to ask or reach out to one of us directly. But we'll begin by doing a brief introduction, a minute or two for each of the providers here.
Thanks, Dr. Reddy. So I'm Jeffrey Pharma. I'm the interim chair of surgery at Fox Chase. I've been here for 15 years and specialize, one of my areas is GI cancers, colon, stomach, small intestine. And just to echo what Dr. Reddy said, and I think what makes Fox Chase such a special place is this is a team sport. We cannot function in silos, and we do that better than any, in my opinion, any of the other institutions around the country in terms of our, what we call multidisciplinary care, which is literally like what we're doing right now. Our clinics, you walk down and we are working together in the same active space on a daily basis. We're discussing cases in real time. I can call anyone at this table at any time of day, night, weekends, and know that I can rely on them like I could my family, to be honest. And that just provides a higher level and really excellent care for our patients. And that's why all of us are here working and value the team approach and who we work with. And so it's a pleasure working here and allowing us to answer new questions and do research projects together and provide the best possible care for our patients. So thanks.
Yeah, he calls me at night all the time. So my name is Josh Meyer. I'm a radiation oncologist, and I treat all different GI cancers, actually. I'm going to be one of the people going into the colorectal group tonight and helping with the discussion there. I agree with Dr. Pharma 100%. I mean, I think multidisciplinary care, team medicine, that's what we do well here. I think this field is a field you go into if you're a team player, if you want to do your best to help the team and have the team help the patient. And I think that's always our goal. And I look forward always to learning from my colleagues and occasionally even teaching them something maybe. So it's a pleasure to be with you tonight, and we look forward to the discussion.
Good evening, everyone. My name is Efrat Dotan, and I'm the head of the GI Medical Oncology Group. The other hat I wear is, as Dr. Reddy mentioned, leading our GI service line from a research perspective. So I oversee a lot of our clinical trials and research operation. And I want to add to what Dr. Pharma and Dr. Meyer said, that I think another thing that brings us all together is a lot of clinical trials and research that we do here with collaboration, very strong collaborations between all of our clinical team as well as our researchers. And there are some researchers down the line here that will speak about that. But I also think that makes us very unique and stand out in our approach in thinking about trials and new studies and new treatment options for all of our patients with GI cancers. So I will be in the colorectal group, and I'm really excited to speak to you guys today.
My name is Vanessa Wuki. I'm one of the medical oncologists, and I treat all different types of GI cancers. But I will be in the liver and biliary group tonight, and I'm really happy to be here with you all.
My name is Igor Asaturov. I am a colleague of Efrat's and Vanessa's, part of the GI team. My personal interest is in cancer genetics and cancer biology. I'm a physician scientist, so do some preclinical drug development and bringing new ideas to the forefront of treatment for various types of GI cancers.
I'm Stephanie Greco. I'm one of the surgical oncologists here. I also treat a variety of GI cancers, colon, rectum, stomach, small intestine. I have a particular interest in colon and rectal cancers that have spread in the abdomen. I think, one of the nice things also about this event that wasn't mentioned was that we get to learn from you all, the patients, what are the questions, that are important to you, what things that you would like to ask, outside of the, office and medical visits. So I think we can learn a lot from you as well, and looking forward to seeing you all in the colon group.
Hey everyone, I'm Dr. Anthony Villano. I'm also a surgical oncologist, one of the newer faculty here at Fox Chase. I also have a particular interest in GI cancers, and part of my research studies outcomes in patients who have colon and rectal diseases. Myself, Dr. Recco, and Dr. Farmer are on a national collaborative studying sort of cutting-edge techniques in treating people with rectal cancer. I have a personal interest in minimally invasive surgery, so if anybody has any questions about that, that'd be interesting to talk about. I'll be in the liver and biliary room, and I'm very proud and excited to be here with all of you tonight.
Good evening, I'm Whit Burrows. I'm a thoracic surgeon. You might wonder, as one of the exhibitors said, what are you doing here? So the esophagus is a large thoracic organ, and one of my expertise is esophageal surgery for esophageal cancer. So that's why I'm here. I'm happy to meet all of you, entertain any questions you might have from that perspective.
Hi, everybody. I'm Mallory Simons. I'm one of the gastroenterologists, but specifically in one of the interventional endoscopists. So I specialize in minimally invasive techniques to treat, prevent any type of malignant diseases, but also the benign sequelae of certain types of GI cancers. And so just because people have a certain type, if you have a cancer, does not mean that you're immune to other types of discomfort that's related to the disease itself. So I like to make sure that I do what I can to make you feel as comfortable as you can and able to eat and go to the bathroom. So that's what I like to make people feel good in that way. And so I'm excited to be a part of this service here.
Hi, good evening, everyone, and thank you for joining us. My name's Angeli Albanese, and I'm one of the social workers here. Oftentimes, people will ask, what does a social worker do? And I know sometimes that varies from place to place. Here at Fox Chase, as you see with all these incredible professionals that you've heard speak before me, we really do approach every person that we meet as a team. So part of my role on that team is to be someone that helps people cope with the emotional impact of a cancer diagnosis, and not just for the person diagnosed, but for everyone that loves and cares for that person as well, because we recognize it doesn't just affect the one person. So we're here to provide emotional support, to help with resources, to be an advocate for you, and just to be part of the team. So if there's anything that we can ever do to help, please always know that you can reach out and request to speak to a social worker. All of the services that we provide here are completely free of charge. There's no billing through your insurance. There are no copays. It's just a benefit of coming to a comprehensive cancer center. So thank you for joining us this evening.
Hi everyone, my name is Jalen Kellogg. I'm an inpatient dietitian here at Fox Chase. I've been here for about 4 years now. I am certified in nutrition support, so the main patients that I see would be patients who have a feeding tube or ones who are on IV nutrition. So whether you're kind of relying on that type of nutrition or you're someone who is able to eventually transition to an oral diet and take food by mouth, I'm here to kind of help guide you through that process. And we also do offer outpatient counseling as well. So when you are discharged, you can always come back to Fox Chase for outpatient counseling to kind of keep you, make sure that you're nourished, and that you can always have, if you have side effects from treatment, if you're losing weight, you'll always have that type of support as well.
Thank you, everybody, for introducing yourselves and showing and really highlighting our GI team here. And you can again see, this is comprised of not just medical personnel, but also dietitians and social worker, and again, the ancillary support that we provide here for the patient's journey throughout their cancer care is important and should not be understated. So we're going to have breakout rooms. There's going to be 3. We have each one of these rooms, one's going to be colorectal, one's going to be stomach and esophageal, and the other one's going to be liver and biliary. And we'll help guide you to the right rooms. The colorectal one will meet here in the cafeteria, and that's going to be led by Doctors Dotan, Greco, and Meyer. The stomach and esophageal we'll go to rooms C and D, which is right over there. We'll help get everybody over there. That's going to be led by Doctors Assatarov, Burrows, and Pharma. And then in Ryman, which is right over there, is going to be the liver and biliary room, led by Dr. Simons, Villano, and Wookie. And then Jalen and Anjali and myself will rotate in the room, so you have the opportunity to meet the entire team, social work and nutrition as well during the time.
My name again is Josh Meyer, and we have Dr. Dotan with us, Dr. Greco, Anjali Albanese, although Anjali is not here for long. So if you have questions for Anjali, you should ask them soon. Anjali is rotating through all the various groups. It's always nice to see everyone here. So if anyone has any questions, either now or at any point in the evening, please feel free to raise your hand, and we can do our best to answer whatever questions you have. It's always really the highlight of the evening is the questions we get from the patients, from the families, and the caregivers who are here. So certainly don't be shy. And if there are no immediate questions, we can talk for a few minutes about what we do for colorectal cancer patients and the things that we are excited about in our particular fields and specialties and the ways that we can support you. I'll start in radiation oncology. I think we've had a lot of progress actually over the last several years in terms of how we treat colorectal cancer. Most of the time, if I'm treating colorectal cancer that has not metastasized, I'm treating rectal cancer because that's the type of cancer that benefits from radiation. But even in that context, things have changed quite a bit, where sometimes now we're able to give shorter courses of radiation. We don't have to give 5 weeks of radiation anymore. We can sometimes give only 5 treatments of radiation, actually. Sometimes we're able to treat rectal cancer aggressively with radiation and avoid surgery in certain patients if we're able to get a really great response and the tumor shrinks away with the combination of radiation and chemotherapy. So that's relatively new, and that's an exciting possibility for certain patients. And then for rectal cancer, I think there's been a lot of progress and interest, and this is actually true for colon cancer also, in patients where cancer has spread outside the rectum, outside the colon, to say the liver or the lungs or sometimes a lymph node or something like that. The opportunity to give radiation with highly precise treatments, a small number of treatments, and be very aggressive in treating metastatic disease, which didn't used to be something that we would do aggressively, but these days we have a lot more information that tells us that actually can help patients in terms of both having fewer symptoms from the cancer, but also in terms of prolonging their life, in terms of delaying any need for chemotherapy. So we do that a fair amount as well. And then occasionally patients do have side effects, pain, nausea, other things, and we can help with that too. So I think I'm often involved either in early stage cancer or in late stage cancer, and sometimes everything in between. So anyway, I'm happy to answer any questions about that, about other things that people are interested in.
So any questions from anybody for Anjali before she leaves us? Okay. So my name is Efrat Dotan, as I mentioned earlier, and I'm a medical oncologist. So those of you who may or may not know, medical oncology are the doctors who are in charge of the chemotherapy. And specifically for colon cancer, we are quite lucky that we have more and more treatment options that are available for our patients. We have learned a lot about the different types of colon cancers, the different biologic types, the different in terms of mutational profile, and have learned how to use new agents to treat this type of cancer. So all of our colon cancer patients now undergo thorough analysis of their tumor. If the patient has metastatic disease, we have a complete genetic evaluation of the tumor, and that helps us understand the molecular profile of your tumor, understand whether there are any other treatment options aside from chemotherapy, if there's any targeted therapy that would be appropriate for your tumor, and understand how we should use the available agent that we have, how we should sequence them, how we should dose them, and whether or not there's any clinical trials that would be available for you. So I've been treating colon cancer for the past 13 or 14 years, and I can tell you that it's pretty amazing to see how the field has evolved, how many opportunities and new agents we have, and clinical trials that are really trying to, develop new and exciting treatments for this disease. So I'm happy to answer any questions that you might have about studies, about these kind of treatments in general. It's still a disease that I'm glad to say that there are many, many, many cases that we can cure, which is always nice to hear, and obviously, advocate for early detection, because that's the best way to find these things early and potentially cure them.
Stephanie Greco, I'm one of the surgical oncologists. So, from a surgery standpoint, I often remind people that, just like my colleagues here, I'm really an oncologist first, because people sometimes wonder, well, why am I coming to you first? Sometimes you don't even need a surgery when I first meet you. And I will say a lot of our patients come and we are the first line people that you see. And so part of my job is to figure out, the whole workup of your disease often, and then to figure out what multidisciplinary care you need. Do you need an operation at all? If so, what's the timing of that? When should I send you to my colleagues here to get chemo or radiation? What other therapies might be beneficial here? Should you be enrolled in a clinical trial? These types of things. So, and as surgeons, we see patients, again, in all different stages. Sometimes, for localized disease, often surgery is the first step, not always, depending on the type of cancer that you have. But, as our other therapies have really advanced, chemotherapy, local therapy such as radiation, we see more patients with metastatic disease who are candidates for surgery. So we see patients, down the line as well, and we really, kind of follow you through the whole process. Also, when we first see patients, it's very important to kind of figure out the site of the cancer. Colon and rectal is kind of lumped together, but they're treated, very differently, and even in the rectum, depending on the location, or the appendix, which is, attached to the colon. Most of our surgeries for these disease sites are really all done minimally invasively. We do a lot of robotic surgery for most of our, localized disease patients. So we've definitely had advances in that realm. As Dr. Meyer mentioned, for rectal cancer, we're avoiding surgery in many cases. We're trying to avoid patients having permanent ostomies, especially for low rectal cancers. So that has been something that's evolving. And we're really here to kind of be, in many cases, the quarterback of the team here, and kind of, get everyone together to kind of come up with the best plan. And certainly happy to answer any specific question.
So just a reminder, I'm Angela Albanese. I'm one of the social workers here. I have the unique privilege of working with an amazing team of doctors who truly value what we bring to each individual person that we work with. We truly recognize that when people come in our front doors, that they were a whole person with a whole life that existed prior to coming here. And the minute that somebody looked at them and said, "You have cancer," it completely changed everything. And so our hope is that we can support you physically, mentally, emotionally, and kind of get you back to what life was like before, to bring you back to all the things that you love most in the world. And so in terms of the support services that we offer individual support, we offer family support, we have support groups. Sometimes patients feel like they connect better when they talk to other patients that are going through something similar. We have a lot of opportunities to provide this support, and so I always tell patients, I'm not here to tell you what would work best, I need you to tell me what works. So I have some patients that say, look, I'll call you if I'm having a bad day, and that's how we leave it. Or I have people who like structure, who say, look, every other week I want you to call me on Tuesday at 10 o'clock, and then that's their dedicated time. So we do whatever works best for you. We realize that for some people the distance can be a factor. It's not always easy to go, hey, I'm trying to work, I'm going through treatment, I don't always feel well. Sometimes I have to ask somebody to give me a ride. I'm not going to come all the way there just to see the social worker. And we understand that. And so that's why we offer phone support for people who want to use like Zoom or, that kind of a video type of conferencing. We offer that as well. The thing I always like to tell everyone is that it's okay to say that you need help or that you're having a hard time, because I'm more worried about people who tell me they're fine. Because I think oftentimes there's so much going on. Maybe they feel fine in that moment, and that's great, but that doesn't mean that there aren't things that they're worrying about or things that they're scared to say out loud. And so we want to be the people that can help support you through that. Sometimes it's nice just to have that outside objective person that you can talk to, because you don't have to make it okay for us. You don't have to protect us from how you feel. And so oftentimes that's where people will say, you know what, I'm glad I talked. Maybe there were things I could say to you that I didn't want to say to my family because I didn't want to upset them or worry them. So we always encourage you to reach out to us if we can help. It's not just the emotional support that we offer. We have resources for financial assistance. We know that this diagnosis affects people in a lot of different ways. If you have to miss time from work, or now you have to worry about the added cost of gas coming back and forth, whatever it is, you can always reach out and say, hey, here's something I need help with. Is it something that you can do? Is there a resource you're aware of? Even if it's not something I directly do, I can at least kind of point you in the right direction and maybe cut down on the number of phone calls or time that you're spending looking things up. We're happy to do that for you. So I always tell people, if there's anything I can do to help, please call me. And if you're not sure, you can always reach out and just talk. And sometimes through that conversation, we figure out ways to help. So please just let us know if there's anything we can do to support you in any way.
Diagnosed with stage 4 colon, spread to my liver, had Dr. Park line all removed everything. And it's fine, that nodule showed up in my lungs. And on this journey, I keep hearing about immunotherapy. And then I'm told that the cancer, or the colorectal cancer that I have, is the most common, 70–80%. It's like a mongrel type. There's some crass in there, some this and that. And it's kind of impossible to cure or treat. Is that true, or is it not?
So, first of all, I'm going to say, it's amazing to hear somebody that is here 9 years after being diagnosed with colon cancer. So that's pretty incredible. These are stories we never heard a decade ago. Immunotherapy is definitely medication that has changed the field significantly. These are amazing drugs that are effective, but in a very small percentage of patients. In colon cancer, there is about 4 to 5% of the patients that actually have tumors that respond to immunotherapy. And as you can understand, it's pretty rare. So the majority of patients have what we call regular colon cancer because they don't respond to immunotherapy. However, there are a few other drugs that we can use. There are different drug combinations. And the other important thing is that in these tumors, we now know that there are other molecular abnormalities that can open up treatment options. I'm just going to say, one example is that until a few years ago, we knew that if a patient had a KRAS mutation, we couldn't do anything about it. And I'm going to say less than, what is it, a year ago maybe? A year. We now know that there is a new drug targeting KRAS mutation G12C. There is another drug that's now under development for G12D. There is another drug under development for G12K. So all these little tiny mutations that are, in small percentages of patients are going to have their own individual drugs. And if we meet again in 10 years, I might be able to sit here and say, now I have all these treatments in my arsenal that I can use for these very small groups of patients. So oncology is changing, and I think the amount of research, the amount of things that are happening is absolutely unbelievable. And I always tell my patients, the longer you live, the more options that you're going to have. I hope I answered your question, but...
So I'm just going to, that was great, and I think it is very exciting, and I agree with you completely that 10 years ago, no one would have stood up and said I was diagnosed with colon cancer 9 years ago. And I'm just going to sort of expand upon what Dr. Dotan was saying. So when she describes a KRAS mutation with G12C or G12D or whatever, what that means is that KRAS is a gene, and there's a particular spot in the DNA that's different from a normal KRAS gene. And when that difference is switched to one, essentially one type of change versus another type of change, those things require different medicines to be active on your cancer. That change affects the cancer cell and its ability to grow, and these different targeted therapies will attack that very specific change. And so it's almost like having your own personal medicine. I mean, it's really amazing. So these are things that really were unimaginable 15 years ago. In fact, KRAS is notorious as a gene that was undruggable, that nobody could make a medicine for. And now we have this sort of explosion of different specific medicines to target it. So it's really exciting. Other questions? I think Anjali is running to her next group, and in fact we have Jalen Kellogg coming in, who is going to be joining us now from nutrition, if anyone has any nutrition questions.
Internet, this and that, and not junk stuff from internet, from big hospitals, Memorial Sloan Kettering, and all the others. And my daughter works in California for Cal Davis, a molecular biologist, and she said they worked on and now has perfected something called genetically modified virus, kills all cancer. It's going through all 3 stages. Now it's the FDA, up to the FDA to prove it or not. I'm just wondering, is this going to take forever, or is it going to be people demand the FDA do it as fast as COVID was developed? It's interesting,
I mean, yeah. The second part I can answer. I think, the FDA is a very complex organization. I can tell you for sure it's not going to be like COVID. Okay, it's going to take a while. I don't know if some of the drug representatives are still here. They can tell you that all their drugs, it takes a long time till it gets approved through the FDA. I'm not aware of this new modality of treatment that you're describing.
Ago was every TV, same night, every TV channel.
Well, it shows you how much TV we watch, right? But I think there is a lot out there. honestly, it is sometimes hard for us to keep up with all the trials. And I do think this is something that makes our team very unique. And this is just not just here. We have a really nice group of oncologists around the Philadelphia area, surgeons, radiation oncologists, and we collaborate with other institutions in terms of research. I often, identify a mutation that I think may be druggable, or a patient may be a candidate for a trial, and we look for trials elsewhere as well if we don't have them here, because obviously we can't have all the studies and all the treatment options. So again, you're describing again what Dr. Meyer and I were saying. There is so much development in this field that new things are coming out every day.
Yeah, I mean, I'd also say that this idea of what we call a viral vector, which gets a therapy into your body and then somehow manipulates your body's own immune system or other parts of your own body to treat that cancer, that isn't something that is entirely new. There are therapies that are approved like that. I don't believe they kill all cancers, but they have some efficacy in certain cancers. And we've also had clinical trials testing other ones here. So we're familiar with the concept, but the specific treatment I'm not that familiar with.
You talked about immunotherapy and so many different advances in that field, but it seems like it's been ages in the options offered for patients that don't really have any immune or any type of mutations in presentation of their cancer. And it seems like, you probably know better than I do, that there are a lot of what they call sporadic cancers, right? Like environmentally. So having said that, my question is really around these medications that cause, really toxic side effects and stuff. Do you offer any other options besides the actual, here's the symptom, here's the side effect, here's the medication? Any other options that you perhaps don't have in this institution, but you work with and suggest, or perhaps think about bringing on board somebody who could be helpful in that regard? I'm speaking from my experience, knowing my body. I am staying away from as much as I can, not to take the medications, because I know I'm just so sensitive, and I could develop other things along with. So I'm looking for other opportunities and options to control the side effects. I understand you can't really choose too many other options as far as the treatment options, but what about side effects? Are there any other opportunities that you could offer in that regard?
I guess I can talk a little bit.
I was actually going to ask Jalen to comment a little bit, because I think oftentimes diet plays a huge role in the types of side effects patients do or do not experience.
So as far as side effects of different treatments, we kind of help patients battle those with, we know that a lot of foods could sometimes make those side effects worse, but foods can also sometimes make them better. In the last breakout room, actually, I was chatting with a gentleman who was saying that he's been losing so much weight because he has such bad diarrhea. He's like, I just can't control it. It's a side effect of his medication. But, the foods that would make it worse, we kind of could strategize on avoiding those. And then not only are there foods that can help to thicken stool and reduce those types of symptoms, but there's other like almost medical foods that are on the market these days that have been really successful. Things as weird as dried banana flakes that patients are having a lot of success with diarrhea. So we've been using those, and it's really any type of, it could be like radiation enteritis, it could be not even treatment related, but C. diff, it could be tube feed diarrhea. But some of these foods are really helpful. And then as far as other symptoms, nausea, vomiting, a lot of those, there's more so with those, it's foods to avoid that can make that worse. A lot of times I do find that different medications for nausea are a little bit easier, but it's also the timing of those medications when you take them before meals. So there's a lot of different strategies as far as nutrition to control some of those symptoms. If you just kind of let your dietitian know, we can work with you on those.
Besides the GI effects, there are other effects, such as...
I think, one thing I'll just add, I think nutrition is a key component. I don't think, a lot of patients ask, well, what foods can I eat to either control their cancer if they don't want to get chemotherapy or prevent it from coming back and these type of things, and we don't know necessarily specific diets or those type of therapies that actually will treat the cancer itself. But I think we have our vitamin D trial, right? Or we've been looking at, there's some things we're looking into about, do certain vitamins help decrease neurotoxicity associated with chemotherapy, additional vitamin D supplementation, these types of things that we, are kind of trying to investigate as adjuncts to help reduce, some of these side effects. But I think nutrition is certainly, a key component. And for other GI symptoms, as Jalen mentioned, there are medications that are in and of themselves fairly benign, but can really help control things like diarrhea and some of the other side effects.
The other thing that I would just highlight is the value of exercise, actually. So there have been a lot of studies that have shown a variety of values of exercise, but certainly they can improve fatigue. Exercise can improve fatigue. Exercise can decrease side effects on treatment. It's been shown both with chemotherapy and radiation. And exercise has also been shown in certain situations to be associated with improved survival. So even simply exercising or not can make a difference in terms of life expectancy, specifically after a cancer diagnosis, colon cancer in particular, actually. So I think that's another piece that is important to try to work into your overall approach as a cancer patient. So I think it's something to consider. The other thing about exercise and diet is it tends to restore a little bit of control and power in a situation where many patients feel powerless. I think that's one of the toughest things about going through a cancer diagnosis is that suddenly people are telling you what to do, what's right for you, making recommendations about your body, and that's really hard. And so what you can control is what you eat and how active you are.
Well, in all honesty, I am coming into this diagnosis with everything I've done right. I know everything that I was doing as far as the nutrition. I was choosing the right foods. I was doing the right things. I was an active person, and yet here I am. So it may work for some people, but for me, my biggest question and concern is how do I go on? What do I need to change from some things that I've done? I thought I was doing everything right, and yet no. So,
well, that's that's the tough thing about getting diagnosed with cancer is patients always ask, well, maybe it's because I ate too much of this or I did.
Right.
It's nothing that you did or necessarily could have done to prevent it. And that's the tough part about this is knowing that this was not something you had control over in the first place.
And yeah, that's exactly my struggle at this point. But it doesn't mean that I'm not looking for other opportunities and options. to improve. There's always room for improvement. That's, I try to see that light at the end of the tunnel, so.
Well, I just want to add, I definitely think nutrition and exercise is important, and that's true across the board, surgery, radiation, chemotherapy. I think you're talking about really chemotherapy side effects that are difficult, and I always tell patients, I can't sugarcoat it. This is chemotherapy.
Right.
So we can't change that. What I can say is that I am glad we're in an era where I do have a lot of supportive medications to chemotherapy. And Dr. Meyer and I still remember when there was none of these supportive medications. We didn't have enough anti-nausea medications that could control this. We had patients being admitted, for days with nausea, needing IV medication because we didn't have oral medication. And to think that now we have multiple different medications to control nausea, and that I can tell patients that most patients are really not nauseous and not throwing up with this, it's pretty amazing. We have medications that come in patches. We have medications that come in small pills under the tongue. We have medications that come in a long formulation that you get one time IV and they last for 3 or 4 days. Even for diarrhea control, we have different types of medications. So you're absolutely right. We have not made tremendous progress in adjusting the chemotherapy agents themselves. I agree with you. I wish we did. But we have made significant progress in the supportive care measures that we have. And I do believe that part of what improves survival and outcomes for patients with cancer is actually the supportive care medications. It's actually, being able to meet with a nutritionist and get that aspect of it, having the data that exercise help and encouraging patients, using all the supportive measures that we have, whatever side effects you get. So I can't take them all away, but I'm glad to say that I do have some ways to support and diminish them.
Any experience with acupuncture in your patient group for the neuropathy particularly, or neurotoxicity, or even nausea and vomiting?
I think there is a role for acupuncture in certain situations. I have had experience of patients who've gone and gotten acupuncture for pain in particular, and it seems to be helpful sometimes. Acupuncture can be used for a number of things, and I feel like it works for some of those and doesn't work for others. I also, frankly, am not an expert in exactly what the benefits are for whom. But yeah, it's another option that can be helpful for people. Are there any other questions? Yes.
How important is organic food?
That's a really good question. So I'm just going to say there's what we call the dirty dozen. So that's foods that if you are going to, if you feel it's important to eat organic, the main thing about organic is it's pesticide free. That doesn't always necessarily mean it's more nutritious or that it's higher in certain vitamins or minerals. That's usually never the case. Really, it just means that it's been grown in a facility that's been proven not to have, contamination from pesticides. So foods that you're worried about would be the dirty dozen, things that don't have, an outer kind of protective casing, shell, peel, something like that. Lettuce, if you are someone who's concerned. But things like bananas, if you peel your apples, they're expensive. And again, it's not proven to be super, at all more nutritious. So at the end of the day, I would say it's not important. I don't buy organic. I like a little bit more money in my wallet. So that's just my personal opinion, and based on the latest research as far as the differences between food from conventional farms and food from organic farms. As far as, again, toxicity from pesticides, I can't really speak to that. But if you are someone who is concerned, if you're going to buy food that doesn't have something to protect it naturally, then you could buy organic.
Does sugar help the cancer grow, or does? Now there's controversy on that, whether it does or doesn't.
That's a really good question. That's actually one of the biggest kind of like myth buster things that we try to tell patients. It is not proven that, people say, will sugar feed my cancer? Our bodies need carbohydrates. So if you don't eat a diet that's high in carbohydrates, your body will break down your muscle and your fat stores to produce glucose, which is our body's main source of energy. It's what our brain functions off of. It's really what kind of keeps us thriving. So we don't want to limit carbs. As far as sugar, no one should really eat a diet that's super high in processed sugars, because that's not good for anyone. It increases your risk of diabetes, which could increase your risk of certain cancers. So really, it's kind of, if you're following a balanced diet and, you're limiting things like processed foods, added sugars, things like that, you're doing your body a favor. But if you have, a little bit of ice cream at the end of the day, is that going to go directly to your cancer? No.
When you're talking about advanced stages of cancer, you've done the traditional treatment, surgery, radiation, you first met the patient, took care of them, and then they have a recurrence, but it's very advanced. And the words are being used to control the cancer versus treat or cure. Do you usually keep someone on chemo indefinitely, incremental doses? What does the research show? Which is the best approach?
That's a really good question. And, this is something that we face quite a lot now that we have colon cancer patients living for years, right? Because, if you ask a medical oncologist, the answer is yes, I want to keep you on chemo forever, all the time. I would want to give you as much chemo as I can all the time. But that's impossible. Nobody can be on chemo forever. And our goal is to prolong your life, control your cancer, and give you quality of life. My goal is not to make your life miserable on chemo nonstop. So there were actually, specifically in colon cancer, studies that were done that looked at the survival of patients with breaks from chemotherapy or switching from chemotherapy to kind of a maintenance treatment where you get low-dose chemotherapy. And the bottom line of these studies was that the survival was the same. Whether you kept the patient on chemo all the time, gave them a break, kept them on maintenance, at the end of the day, the survival was the same because when the tumor started to grow again, you put the patient back on chemotherapy. So what I do with my patients is we play it by ear. We see how they're feeling. If the patient is doing really well, if they're not having a lot of side effects, we keep the chemo going as long as we can. We switch to maintenance when we can. We take breaks. Vacations, trips, things you want to do are really important. That's why we're giving you chemo, to prolong your life with quality of life and allow you to do things that you want to do. And I will always prioritize that over giving another dose of chemo. So obviously every case is different, but I think that's sort of the goal that we have. I just wanted to add one more comment about the sugar, because I know, honestly, if I had, a dime for every patient that asked me this, I think at the end of the day, as was said earlier, our body needs sugar, and you're going to read a lot about things that you shouldn't do or shouldn't eat, and I have seen patients that have taken that very literally, and honestly, I think that affected their survival more than anything, more than the cancer, more than the treatments, because their body broke down because of lack of energy, lack of calories, lack of ability to fight or receive therapy. So well-balanced diet, sometimes sugar, that's never going to hurt you, and, making sure that you're giving yourself enough nutrition and enough calories to be able to receive treatment and really, face this disease. I think that's the most important thing. Any other questions? We have Dr. Reddy here too, if anybody wants to ask questions.
We probably have time for one or two more questions, if anyone has anything particular they're interested in. All right. Well, really was a pleasure being with you tonight, and I'll speak for the panel for Dr. Reddy and just tell you that it's really been enjoyable. This has been recorded. You see our videographer here right in front of you who's been helping us, and so we are going to upload it to the Fox Chase YouTube page, and you or anyone else will be able to view it there. And please check our website for upcoming patient programs and events, and please save the date of July 1st for our annual Survivors Celebration, and you'll get an email or a mailing list, piece of mail in the mail about that. But otherwise, thank you again for joining us. Oh yeah, please, at the bell. So I'll repeat the question in case anyone didn't hear. So the question was about patients who have cancer and then, a long time later, say 9 years later, develop cancer again. Are there studies around that? And actually, Dr. Greco has a particular interest in that, and maybe she could comment.
Now, are you referring to the same cancer or a different cancer? A different cancer. Yeah, so that's a good question. So, regarding different cancers, yes, definitely there are patients that we know have specific hereditary mutations, for example, who are more prone to getting, different types of cancers in the disease site. We try, that's one of the things we look at when we see a new patient. We try to determine what is the chance that this is something that's actually hereditary. We have a great, risk assessment program here that does genetic testing. We'll work you up to see if you, kind of have a suspicion for a hereditary mutation and need to get genetic testing done. There are certain patients with certain diagnoses where that's kind of standard that you get genetic testing done because of the incidence of having, a hereditary mutation. So definitely we see a lot of patients with hereditary mutations, multiple cancers from different disease sites. And again, as I mentioned, most cancers are sporadic, not hereditary. There are certain cancers that go together where we suspect something may be genetic related. And then regarding, the same cancer coming back, certainly, and that risk is determined by, your cancer site, your original stage and things like that. But I always tell patients that even once you're cured, it can still come back. And that's why, we're following you for a long time, usually, even after your curative treatment.
The other thing to remember is that, unfortunately, colorectal cancer is one of the more common cancer types. And just because your colorectal cancer has been treated effectively, unfortunately, doesn't mean you get a pass on the rest of the cancers. And so things that are common like breast cancer or prostate cancer could come up, and they may have nothing to do with your original cancer. They just, are a function of the fact that they're common. Cancer is unfortunately pretty common in the population. So I think sometimes it's just chance. It doesn't have anything to do, again, with something you did wrong. It doesn't necessarily even have to do with, an environmental exposure that we're aware of. It's just sporadic, as Dr. Greco said. Any other last-minute questions? All right, well, yes, please.
A small plug here to sort of, again, just highlight the team approach. We have back there's some pamphlets for new patients and caregivers, a patient-to-patient network. It's quite remarkable. I've had several patients participate in this where it's sometimes nice just to talk to another patient to get their experience and sort of see how they handle things. But it's not just for the patient, it's also for the caregiver. It's a good opportunity for caregivers to talk to other caregivers on how do you take care of somebody in this situation. So back there's going to be a couple pamphlets with some information about it. I do think it's helpful, and obviously share this information to others because we're happy to provide that support for patients.
Thanks very much, and good night, everyone.
We've always gone to Philadelphia doctors, and I also had a brain tumor, but was benign. But I've always had autoimmune problems. I have other underlying issues, so it's again, you don't know if that's an issue, if it's something else. So you're always looking for other issues, but it's come back to no, it's the cancer, and the doctor shouldn't be knowing what's going on, and they're not even looking for anything else. They're just there's nothing we can do. So now I'm here and I'm asking, is there something else to do? Is there another treatment? Is there something, what do we do?
And you said you were on the octreotide side, right? Yeah. Well, I would say, and unfortunately for this kind of type of stuff, I always feel a little sad because as a surgeon, our role becomes very minimal, unfortunately, when things get to the liver. But believe it or not, sometimes there are surgical roles. It sort of depends, but in terms of like cutting edge treatment and stuff, surgeons always kind of at least play a role in the beginning because the scans, as you know, are super important because they can help us decide if the surgeon can help with some of this stuff. And you said you had neuroendocrine tumor. Often we can do things surgically and maybe not get all of it out, but we do get most of it out, and sometimes that does help some people. But it's a very nuanced decision when we make those decisions, and it's right for some people, not right for others. Usually people are on medication just like yourself for quite a while before we make those types of decisions. Dr. Vijay Virgia is usually really, really great about it. She works with us real closely in terms of figuring out who are the right people to send to Dr. Villano or Dr. Castellanos, some of my partners, to kind of sort out, is surgery really the right thing to do? And then if we look at things and we're like, maybe it's not the right move, then I lean very heavily on Dr. Wookie and Dr. Simons to kind of help out with those sorts of things. But certainly I think, as of right now, there's nowadays, thankfully, more and more options becoming available for folks. Research has been really like almost exponential in the past 10, 15 years. It's almost hard to keep up with how much new stuff there is out there. I can't speak to it as well as these guys can, but certainly I think, you're asking the right questions. I mean, it's always right to be asking, what else can we do? What's the next step? What do we do next? I don't know, I think maybe broadly we can sort of speak on some of that stuff, without meeting you, in the office it's hard to ever say what the exact right thing is for you. Dr. Vijay Virgia can review your stuff, but certainly I think we could speak to a little bit of, what are the cutting edge stuff nowadays, the new things we've been learning, maybe that kind of give you
I'm
an
at the point
idea.
where I think a
Help
new
other
set of
people
eyes would be
tune in and watching something.
beneficial to her.
Yeah.
Right.
And she really liked Dr. VJ when she was here
Right.
before with her.
And I know I've heard of that there's radiation. There's also new medications out there. It's like it's not just surgery. There's different medications. Like I said, there's radiation. There's different ways of going about it. So immunotherapy, it's all different ways of going about it. So it's just, I'm open to anything. I'm willing to try anything at all that's out there, and I want to hear what there is, and I want to hear what is the better route of going. I'm 64 years old. I have grandchildren, great-grandchildren. I want to be here for a while. I'm not ready to, shut down and say, okay, I'm done living. And I don't want to spend it, between a hall and a bathroom. It's, and exhausted when I'm finished with the treatment. It's tiresome. And I want to know that there's something else besides what I'm doing. There has to be an alternative to what's going on. And again, money. I do have other illnesses, but yet they're not something that's going to kill me in the next 10, 15 years. So what do I do? Give me options.
Is it mainly the symptoms that are getting worse, or is it like the cancer itself that's growing?
No, the symptoms that are worse. I mean, I'm in the bathroom, I'm in pain, I'm exhausted because it's depleting me. So, I mean, those are the things that I can't deal with. I mean, the other things, it's like, okay, there's something that'll stretch it out, so there's something that, and the medication is keeping it from spreading. It's holding from spreading, so that's a good thing.
Mm-hmm.
But the side effects are horrendous. My hair's falling out, my teeth are getting bad, I'm running into all different side effects. And the main thing that I can't stand is the bathroom, that I can't, I'm for weeks in the house and not able to get out of the house. And again, that's having an effect that it's, doing a number on me.
Yeah.
And that's the main thing that I need to fix. And with fixing that, I'm sure the other issues will go away. So what do I do to fix that? The 3 weeks
And
has
how
been
long have you been on
probably
the
last
octreotide for the every 3 weeks?
6 to 8 months.
Yes, probably
It was 4 weeks.
It was 4 weeks prior to that for the past,
Years.
yeah, quite a few years now.
Yes, I mean, there are other options that we do for treatment of the cancer itself. They don't always, with all of those treatments, we still do like the octreotide and things, because that's really the best thing that helps with symptoms. There are some other medicines that can be added to help more of the symptoms that don't, target the cancer as much. And so kind of without knowing exactly kind of what the cancer is doing, those treatments, kind of all have side effects too. Mm-hmm. And so it would kind of be that discussion, sitting down and, here are some of the options, and yeah. And so, but there are other options to kind of treat the cancer, and some of that depends on, certain characteristics of your cancer too. Mm-hmm. Yeah. Mm-hmm. I will say the side effects tend to be harder to treat, because the cancer itself makes kind of some of those hormones that cause you to go to the bathroom and all of that.
Neuroendocrine tumors are a funny type of tumor because they all behave very differently. It's kind of like, it sounds like it's just one name and that they all should kind of be the same type of thing, but they all behave very, very differently. So we kind of take it on a very patient-by-patient basis, because the characteristics, like Dr. Wookie said, guide a lot of what we end up doing. And a lot of that varies from person to person. It kind of opens doors for certain types of treatments. Sometimes that makes other treatments not something we should think about. It's the same way with surgery. So for some patients that have types of neuroendocrine tumor, it's really good to do surgery, and even some people it helps your symptoms. But I would say that there are other types where even if people have symptoms, surgery, or even what we call like local regional therapies, where we treat the liver with other things like radiation or kind of special medications where we can inject them into the liver, those types of things may not be good for everybody. And so it really is sort of one of those things where you take it by a case-by-case basis. Fortunately, nowadays we have more options than we used to treat those kinds of things. I think as of right now, it sounds like an adjustment was made and it's not exactly working the way they wanted it to. And so entertaining other things is certainly something to just consider with, Dr. Vijay Virgin and the rest of our team, when he comes to your visits. And I'm certain by now she probably at least showed the scans to one of the surgeons, but we can get involved with the case too at some point just to look and see. But fortunately here, when you come to your appointments down that hallway in Young Pavilion, we're all in that and seeing patients. I see patients the same day as Dr. Wookie, so when I have questions, I just walk down the hallway and I say, hey, Dr. Wookie, what's going on here with, I have a patient, I have a question about some, new chemotherapy or systemic treatments that, as a humble surgeon over here, I don't know as much about, and she gives me advice right away. And same thing with Dr. Simons. I have her cell phone. If I have patients where I think, maybe some sort of new endoscopic treatment or something could be available, like give her a ring and just sort of see. So those are the kinds of ways that, you know, we try to interact with each other sort of behind the scenes. Even when you see one doctor, you probably got a couple other opinions and you don't really even know it because we're looking at your case together.
We want to start off by answering any questions that anyone has, or we can give you an overview, whatever anyone would like. Does anyone have, why don't we start off with some questions if anyone has?
Or just tell us your stories and we can go from there.
Okay, I'll start.
If you don't mind, yeah, as long as you're comfortable with that. Again, we're not filming face or anything.
Maybe you can pass it along. No, not portable. Yeah, we can hear you.
Oh, you can hear me?
For the video.
Oh, okay.
Yeah.
Okay.
Sorry.
Well, okay, I've been undergoing treatment here at Fox Chase for approximately 14 months. I guess I don't know how to pronounce it, but neuroendocrine tumor?
Yeah, neuroendocrine, yeah.
Yeah, so the weight loss kind of snuck up on me, believe it or not. I mean, I don't know how that happens, but it did. And so I was experiencing pain in my stomach off and on for a period of 2 to 3 months, and maybe a little longer than that. And so I decided to, come in and check with my primary care doctor, who sent me for some CAT scans, and that happened. And then ultimately, I ended up here at Fox Chase and been undergoing treatment. And I was telling my wife, really, it's like it's happening to someone else. It's like I've kind of separated myself, from what's going on. The pain that, intermittent pain that happens. And I've been in touch with my doctor, who has prescribed some remedies to help me deal with my pain. And recently, the big issue with me now is that when I eat a meal, I almost immediately have to have a bowel movement that's pretty loose. So I've been taking Imodium, and then the monthly injections that I've had have been switched up, where I'm now getting, instead of one injection a month, I'm getting 2 injections simultaneously, whatever the dosage, to help with that. So that's where I'm at, and mentally and emotionally working my way. I can see from where I started out last year that I'm dealing with the whole situation much better, but still it's, sometimes you're like, is this happening to me? So I'm just trying to work my way through it.
We didn't get your name.
Oh, Derek.
Derek, thank you.
Uh-huh.
So this is potentially carcinoid type of neuroendocrine tumor?
Pardon me?
Did they say like carcinoid? Did they say carcinoid? Was there a word of carcinoid?
I'd have to look at, the write-ups afterwards, as far as, what my doctor wrote up. Sharon, I don't know if you...
Mm-hmm.
I don't recall that.
Yeah.
Mm-hmm. Okay. But it's the diarrheal sort of manifestation is the part of the disease process. That's how you understand. Yeah.
So, I've been in touch with the doctors if I have any concerns, and so that's where we are right now. So,
what are you doing, Derek, to build up your lost weight? What's your strategy?
I'm eating more often smaller meals, taking in protein drinks, which I don't really like, but I do it anyway. So, and I've been in touch with the dietitian, who has provided me pamphlets and tips on how to eat, and I've been doing my best to stick with it, as far as building my weight back up. So,
I was going to recommend, I didn't know if you were seeing a dietitian as an outpatient, but Jackie is our outpatient dietitian, and she's really great. And she actually offers telehealth right now. So your first visit is, So your first visit is typically like an hour long over the phone. And she's, we kind of help you manage those symptoms. And there's way more than I can say in a couple minutes right now as far as how to manage diarrhea with food. But not only are there foods that make diarrhea worse, but there are foods you can eat that make it a lot better.
And there's newer products on the market that really help with diarrhea as well. Things you wouldn't even be thinking of, like dried banana flakes, things like that, that I use for inpatients, like patients who are admitted, and they've had a lot of success. So these are things that, I'm sure Jackie will continue to counsel you on, but there's definitely some ways to kind of help control that.
I think I have been in touch with Jackie, and the diarrhea, it's only been recent that it's gotten to this point. Like earlier, 6 to 8 months ago, it was not an issue, so so now I'm dealing with it, and there are days where I don't have an issue with it, and then some days, I do. So.
Good. Well, by controlling the diarrhea, it would be easier for you to put on some weight. Sometimes when you have diarrhea, even if you're eating a bunch, you're not absorbing the nutrients from those foods. So hopefully if that's a little bit better controlled, you'll be able to maintain your weight better. And there's a lot of other products. You said you didn't like your protein shakes. There's some better ones out there now. Boost and Ensure, they're okay, but there's some other ones that she can talk to you about.
Okay.
What foods do you recommend? You were saying there's a lot of foods.
Foods that help to thicken stool would be, things like bananas, applesauce, anything with like pectin in it. You could even take pectin powder and mix it in with things. Other bulking foods would be like white grain products, things like rice, cream of rice, cream of wheat. You could do cottage cheese is weirdly very binding. So those are all foods that help to thicken stool, but wouldn't necessarily cause constipation. So it wouldn't cause, just the opposite problem. But foods that tend to make diarrhea worse would be things like high-fat food and foods that are high in insoluble fiber, so like your raw fruits and vegetables. These are all things that can kind of irritate the gut a little bit. The fat foods go through your digestive tract a lot quicker, so those can kind of, like fried foods, high-fat, like steak and red meats, things like that you want to avoid.
And another consideration along the same lines, you may want to check with your doctors whether your body is processing the food properly in the intestinal tract, whether you may be benefiting potentially from digestive enzymes. So many of my patients take those enzymes like Creon and some other newer products that are available on the market. You take it right with the meal, and it helps the body to process the food better.
And the dietitian did bring up many of the things that you just mentioned, and I have been trying them. So it has gotten better, but it's not a consistent better. So sometimes it's better, and then some a day or so. And I watch what I eat. I kind of go back and say, what did I eat that might have triggered that? So.
Good. Thanks, Derek.
Are there any other questions? No? Okay, sure.
It's a happy
Well, my name is Pat. Here? Just unscrew it.
Look at you. I was
One of my challenges in life. Thank you. All right. About 3 years ago, in this coming August, I had a massive hemorrhage, and was rushed into the hospital and was within 1 hour diagnosed with a GIST. I never knew I had it. I probably could have had it for 10 years prior to that. Also, it was large. It was 6.5 cm, so, or millimeters, centimeters, yeah. And yeah, it was large. So I never knew I had it. And I immediately started I went to a surgeon who said it's too large, we have to shrink it. I went to Dr. Rosado at Jefferson because I ended up at a Jefferson nearby. And after, I would say 4 or 5 months, I had surgery, and it was malignant. And I've been on Gleevec since, and I have a little bit of every side effect that you can have, but it's all tolerable. The thing that bothers me the most, and I don't know how to get rid of it, is fluid retention. I have it around my eyes. I want to, rip my eyes out sometimes. It's so irritating. But other than that, I'm good. And I go for CTs every 3 months here. I'm still under Dr. Von Mieren's care. The thing that bothers me is that I come from a family of cancer, all different kinds of cancer, and I feel like it's always chasing me. Why do I have to go every 3 months for 3 years? What is everybody waiting for? I'm just afraid it's going to come back, and it might not. I know somebody 12 years who had metastasis. I had no metastasis, and they're on Gleevec. And what are the percentages of this returning I know cancer doesn't have a conscience, so I thought that the highest, if it was going to come back, the most times it comes back, it's within the first 2 years. Is that true, or is it a lifetime?
So probably I see the most just from a surgical standpoint, and I work with Dr. Von Mieren all the time. Within 2 years is usually the most likely time that can occur. However, we follow patients with just up to 10 years, really. And at 10 years, then we probably still follow, even though, we increase the time frame when it's not every 3 months. It goes every 3 months, then 6 months, then every year, once a year. And the feelings that you're having, I think, for all cancers are exceedingly common. Some have phrased it scanxiety, and the idea of, every time you're coming in, and that's hard for, I think, all the patients that walk in our doors every single day, like coming and getting your scans, what's it's going to show, and we try to expedite, and now it's actually a little better that you can check on your portal, like maybe get it faster, and all these things, but that's a very, very normal feeling that you're having, and I wish that we could say, like, oh, what are we going to do? GIST are unique tumors that, thankfully, we have this amazing drug. It was initially on Time magazine as a silver bullet, like this one medicine that we know targeted these tumors, that was really the first proof of principle that we can have a target on a cancer and we can have a medicine that can affect that. And imatinib that you're on was really revolutionary. And the good thing, even God forbid if it was to come back, patients with GIST tumors, even if it comes back, live many, many, many years, which that's a positive. And there's a lot of things that we have that we can do to treat them if, God forbid, it came back. In terms of percentages, Dr. Von Mieren, next time you see her, would be the best person to talk to. We can plug in information into something called a nomogram, where we put in your age and characteristics of the tumor and the size of the tumor. That can really, if you really want to know specifics of percentages, we can tell you that information by putting that information in. And Dr. Von Mieren, you may know or not know, but she is like a world expert on GIST tumors. Like, it's amazing. Like, and that's one of the things that when we work here at Fox Chase, you're literally working. We just had our surgical oncology. We have a fellows, so they come and train with us for all the specialties we work in. And we have interviews today. And so we, attract fellows from around the country. And one of the things that draws people is here, like, you're walking around the hall, and including, myself at this point and others, with experts in the field that have written the guidelines and who sit on the guidelines and are really experts. And Dr. Von Mieren is one of them. I feel very privileged in our sarcoma team to work with her on a daily basis, because she leads the NCCN guidelines for sarcoma. So she could tell you that information. Kind of a global comment about that information is, I think those percentages for all patients with cancer is a little hard to digest. And maybe you can both comment too. It's like, how do you take a percentage and individualize that for your own self, or how does that, it's good to have an idea, I guess, and that makes it helpful, but it's still, if someone says, well, a 30% chance it could come back within 5 years, I find those numbers, and I'm not saying that's your number, I'm just making it up. But what does that mean for you individually? It's very hard to interpret that and individualize that information. So as much as we have information, and so many situations are unique, and also a lot of those percentages are different than what we have. So for just tumors now. We have second and third line agents that if God forbid it comes back, we have another drug that we can give you. And if that doesn't work, we have another drug we can give you. And sometimes we can go in and operate. And so there's all these levels of things that we do. And so I think the number one thing is, having done this for a while, is, you just have to be, I wouldn't fix it, and it's easy for me to say this, but don't fixate on the negative. Like, it's great. You're doing amazing. You're tolerating, and as much as you have some of these side effects, it comes in with the turf, and Dr. Von Meeren can help mitigate some of those things, because she, again, has been using this drug more than probably anyone else in the country, and the chance of it coming back is low. It's not zero, and I wish we could all say that, but that's why we have this regimen of how we follow you. And with time, that will expand, and then you don't have to think about it for 6 months, and then you don't have to think about it for a year. And so those are just kind of my overall comments.
But time is working for you. Time is working for you. The more time you put between the date when you had surgery to the present time, the better it gets.
She's wonderful. I feel very, very fortunate that I live in the area that's, convenient to see her so often.
I also wanted to tell you the fact that Gleevec was invented in the first place is thanks to the discovery that was made in 1959, the discovery of Philadelphia chromosome. So 2 floors up from where we're sitting here in this room, 2 floors up, one graduate student was looking at the metaphase spreading of the chromosomes from patients from Pennsylvania hospital who had myeloid leukemia, chronic myeloid leukemia. And he noticed that there is a elongation of one arm of the chromosomes. And that was the discovery, the first genetic causality. Because back then in 1960s, 1950s, people didn't know about what causes cancer. Is it viruses, which is true? Is it chemical, or is it genetic alterations? The chromosome, the DNA was just discovered as a structure. In fact, some of these pictures related to this. So you can imagine from 1959 to almost half a century later, from the discovery of the chromosomal alteration that activates this gene to the creation of the drug, passed almost 50 years. Now, the pace of progress and the pace of science is so much more accelerated that it takes probably just a couple of years before they discover a target to develop in clinical trials of a new drug. So everything is getting compressed and becoming much, much faster. So, I don't want to predict this for you. You probably won't benefit from these advancements, and hopefully you won't ever need to deal with your diagnosis, only as a good, social visit with Dr. Von Meeren. But patients who do have this disease that is persistent, every year they get a new option for treatment. So the future is getting better and better, and the longer we live, the longer we put time behind ourselves, the better it gets.
Thank you. That's amazing. It's almost hard to comprehend how far cancer. I was in the medical profession. I was an old nurse, and I remember when it was a death sentence, and now, from what I read, over 50% of people that are diagnosed with cancer live longer than 10 years. So it's just amazing to me. Thank you all.
You like the numbers. Look at you with your statistics. 50%.
I hope it's true.
And by the way, among the side effects of Gleevec is a graying of the hair. So one of my patients, a young man, he had taken Gleevec for a few months, and he noticed, he came to visit, he completely turned gray. And then we stopped Gleevec after a certain time, and he changed the color of his hair. So I wonder, what happens with your color, hair color. Right.
I'll let you know.
Should I tell my story?
Sure.
Yeah.
Mine is for all of you. All right, hi. Thanks for the time tonight, doctors. My name's Steve. I too was diagnosed with a GIST tumor. I had no idea how long I had it. If I had a guess based upon symptoms that I kind of retrospectively looked at, maybe 5 years. And mine was 8 centimeters, sitting right about yo. And I found out I had it, which after a night of, I thought, one too many martinis and really bad stomach pains the next day. And here, my stomach had perforated because it had metastasized. And so I went to Einstein up in West Norton, in Montgomery, and they did emergency surgery and took out my esophagus, my stomach, the tumor. And 30 days later, they discharged me from the hospital and started me on Gleevec. So I'm coming up on 2 years for all of that. I had an ostomy bag on my chest for 15 months and a G-tube for all my feeding for that whole time. At first, I was like, what the heck happened? And how long is it going to be before I'm back to normal? And that was probably my biggest frustration, was lack of information. I'm a CPA, investment manager, and data analytic, nerd. Like, I need information. I need all of that stuff. And at Einstein, I was like, a month. You'll be back together in a month. I wasn't even out of the hospital in a month. And so once I started the Gleevec, the PET scans were very, very positive. And by March of 21, or 22, I was clear. All the nodules were gone, and I was officially, in remission, no visible cancer. Which at the time, so this was oncology at Einstein still, they were amazed that I was able to respond that quickly. I still had an ostomy bag and a feeding tube, but at that point, I was living life. I was on airplanes, I was flying, working, I was speaking at conferences, I was taking vacations, and truth be told, I'd go to the bar and I'd put a drink down the tube and the bag, and it didn't bother me at all. And I literally never thought that I had cancer. I just okay, I hurt my foot. I twisted my ankle, and it was just something that I dealt with every day. And I hit the ground, I got up and I did my thing. And, the whole time working with, what started out with Dr. Erkman at Einstein. And when Einstein declined to put me back together, Dr. Erkman, brought me right down to Temple, introduced me to Dr. Pharma, and the process started there. And it took 15 months. And that was probably, out of everything I went through, and people can't believe, they look at me and they're like, how could you deal with not eating for 15 months? I'm like, what choice did I have? And I just, put a pump on at night, ate my protein shakes and got up and lived my life the next day. And, but not knowing it was going to take 15 months to reconstruct me was probably the only frustration I had through the process. And part of it was, I didn't appreciate how difficult the surgery was. From the time the cancer went into remission to all my pre-op testing and all the prep and planning that Dr. Erkman and Pharma had to do, I just thought it was fix my broken leg. I didn't realize replumbing me was as difficult and as complicated as it was. And, but once the glide path got set for all of that, it was okay, what do I got to do to make this as successful as I could? And August 16th, I went in, and 9 days later, I was out at home, and okay, let's back to the beach. And, and I started eating via mouth again October 15th, 2 months after the surgery, and pulled the tubes right after Thanksgiving, and I've been rocking and rolling ever since. So, my observation, and I know it's difficult, Dr. Pharma, as you said, to individualize certain things, but I needed more information. And you were good, and you were very optimistic. Dr. Erkman was a little more tentative with her, but I love her. She's fantastic. And, but I had a plan in my own mind what to expect and how to deal with it. And that was probably my only frustration through the process was as my personality, my CPA analness needed that information so I can plan better around it. Even if it was, can I go to the beach this weekend? And, can I live the life that I had constructed for myself under the circumstances? Since then, everything, it's a learning process. So as I got reconstructed with my new esophagus from my colon and my new stomach and everything, so my clavicle and my first rib is removed here. So, I got a lot of pain from my arm hanging without the skeletal support, and I got to deal with that. And riding motorcycles and golfing is like a whole new thing. And my stomach's really small, so I got to eat like 8 times a day. I feel like I'm constantly eating. And, sometimes from a nutritional perspective, I'm fine. Other times, diarrhea, like it goes right through me, like Derek said. Like I literally eat breakfast and it's like, oh, I got to go to the bathroom. And I keep track of what I eat, so I try to see nutritionally if there's something that triggers it or not, but I can't figure it out. But sometimes I'll go weeks where I'm like totally, normal, and other times where it's just like I can't keep anything in. But, if I miss a meal, like during the day, I'll lose 5 pounds. And then it takes 3 days to put those 5 pounds back on. So those are the things that I'm just dealing with, like kind of learning how to live with my new self and, my new systems. And I think everything's pretty stable. I feel great. My energy levels kind of go up and down, but, sometimes I think it's because I overdo it. And, I think I'm 20 years old again. I just could go back and do everything I used to do. And the reality is I'll probably never be that way, but I just have to, curtail it a little bit and pull it back in. But, those are, my observations, my questions are really like, more information for me would have been better. Having a, more regimented nutritional plan other than kind of figuring it out, trial and error type of thing, which is really what I've done. And, I'm back at the gym. I'm putting muscle mass back on and weight that I had lost over 2 years of not. But I still, I'm trying to manage my energy levels. And, those are the types of things that, kind of additional help and input would be great for anybody going through the journey. So, but, I've never been down on it. I've always had like an amazing positive attitude about everything. And just, I think everyone here with, through the Temple system and Fox Chase that's the reason why I'm here. And, I couldn't be happier with the results of the teams. So thanks.
Thank you for your story.
I think it's important for us to hear, and we met, a little later on in your kind of journey, you and I, but it's important for us to hear, and I think, and also for patients that, that information is important. And sometimes, we're in clinic, busy, and like sometimes I think patients have to be advocates. We have to sometimes pause and make sure we're providing the information that patients want, because some patients want all different types of information. But I think it's important for us to hear that as well, that, what does this look like? Again, I met you later on, but 15 months was a long time. And like, I highly doubt that initially when they, you had the operation at Einstein, that they were anticipating you were going to go that long for 15 months. And I think, yeah. No. Yeah, 1 month is not the case. And I think from, the advocating for yourself, the things that are important. And I do think that there are these thing, and she had left, but like nutrition's really important. And I do think that sometimes we get focused as providers on the treatments and the surgery and the side effects. And sometimes we don't do the best job of kind of the life situations and day-to-day things. And I think it's always important for us to hear that, because we want to always improve and get better. And we definitely have more robust access to our nutritionist now, or physical therapy. And I think we are all looking at it as a team on how to improve how even before treatment, we can maximize physical therapy or what we call prehabilitation or nutrition input, because it's the continuum. It's not just like, we shouldn't just identify this when you're at the lowest that, okay, now we bring nutrition in. I think we're learning that we should do all this up front, and also the mental component to all of this. And I think that's really important. So we are definitely always thinking about these things, and there's definitely things that we're working to improve on a daily basis in all the aspects of what we do. So.
One other observation, which I forgot to bring up. So I am on Gleevec, and as of right now, I'll be on forever.
Yep.
You know, my gray hair came in the last couple of years, so I'm like, what the heck happened? I had brown hair forever until I looked in the mirror one day. But what do I have to worry about being on Gleevec forever? Does anybody even know, like, how long, somebody's been on there, and is there anything else I need to worry about?
Excuse me. What is this Gleevec?
So it's a type of oral chemotherapy. It's something called targeted therapy. So there's a mutation on these specific rare types of tumors called gastrointestinal stromal tumors, and this is a type of oral chemotherapy that can shrink these tumors or decrease the chance of them coming back. So we have had patients, you may know more than, but I would suspect we're over 20 years, I think. Do you know? 20 years? I think it's probably about 20 years that we've been treating patients with this drug. And there are patients who have been treated here for that amount of time. So to my knowledge, and Dr. Von Maren's the best person, and we can find out, but I think that there's not these long-term, like, latent side effects or toxicities associated with this medication. So it is a pretty safe medication, has side effects that both you can attest to, but low side effect profile and really not long-term like side effects. So
I would say the only kind of daily issue I have is I get 15 minutes of nausea first thing in the morning when I take it, and then it clears right out. I'm fine.
Yeah.
Other than my gray hair.
Do you take it with food or?
I take a little bit of food.
Yeah.
Again, my issue is my stomach's so
No,
small.
you don't have a stomach, yeah.
So I got to be really careful.
Sure.
So like a little muffin, and then I take the pill, and then I try to have like my normal breakfast, protein and stuff. Sure. But that's really the only thing I deal with day to day. I don't notice any other side effects of your experience.
Try carbs. Try. Some ladies say half a bagel.
Yeah.
Try.
I literally eat a little corn muffin before I take it.
A little one?
A little one, yeah.
No, carbs are good with Gleevec.
Yeah.
I know two people taking it.
Well, again, I don't have the same stomach you have. My stomach's like this big.
Yeah.
So I gotta be careful. I have, volume's my biggest issue.
Yeah.
So, but that's, other than that, I just, since I know I'm gonna be on it forever, is there anything else I gotta be concerned with?
No, I mean, you're followed like, same sort of thing in terms of surveillance and follow-up, but I don't think anything specifically. I would just comment along my lines of earlier discussions, like with your surgery, like working as a team is so important. Like there was 3 surgeons involved in the surgery, a lot of planning, and those are things that we are able to do here that a lot of other centers are not able to do, just because of, 1, our expertise, 2, being able to work together and do a community hospital, for instance, wouldn't be able to do this type of thing. And even Einstein was uncomfortable, correct. Yep. And we have staff here for all aspects that allow us to do really extensive surgeries and think outside the box at time and work to the teams to do things that other places can't, which is why a lot of us are here.
Well, the day of my surgery, I met 50 people that came in beforehand. I was like, okay, I think I got everybody here.
Yeah.
But all your 3 stories are just great stories of human resilience and not giving up under difficult circumstances. In fact, personally, myself and many of my colleagues, we learned from you for our own experiences in life, how to be resilient. Like one patient I currently taken care of. He's a quadriplegic since he was young. He's in his mid-60s now. And he lived almost all his life as a quadriplegic man, independently, on his own. And was diagnosed with metastatic colon cancer. But any time he comes in, despite having complications and reactions to chemotherapies, he always comes with a smile. And I always wonder, what puts a smile on his face? And he's like, "Hey, doc, I'm fine. It's just another day." These lessons are extremely valuable, and because these are human lessons, we're all learning from you. So even though you feel like sometimes this diagnosis comes as a shock, and I totally understand how it feels. But at the same time, just be aware that you're not alone. There is a team around you. And there are many patients and other human beings who are in a similar boat. And they keep paddling. They don't give up. So keep your work.
The other comment that I would make, if I could, because I'm reconstructed, there's a good chance I'm going to wear out my new parts.
Well, not really. So I'm Dr. Erkman's newest partner, meaning, but I'm older than her in terms of thoracic surgery. I've been in thoracic surgery for 22 years, and I just want to give you a perspective to echo what was just said, and integrate something that you said. So I marvel at how alive you are.
Thank you.
Okay? All of you. You too, Derek. Meaning, I constantly say, what if I was you? Would I have that will, that strength? Because that's what it demands. To live with a stoma on your chest cavity and a feeding tube for 15 months, to have a fear that when is this maybe going to come back, to be 18 months into a process and have diarrhea every single day, I don't know what I would do, despite having the experience of treating hundreds and hundreds of patients. So I just want to echo, it is a testimony to your, not necessarily our expertise, obviously we're here, and your testimony to our expertise, but it has to be a tango and a dance, meaning it takes two to tango. We need our patients to be like you guys. So I've been doing, again, 22 years. I would have no idea that you have a colonic interposition, okay? I would have no idea that for the last 16 to 18 months, you've been as sick as you have been. I mean, yes, you look sickly, but not to the point that I would have any idea of what you've been through. And I think that's what our comprehensive care, that kind of appreciation, little integration of that, that's what we can't lose sight of. So that's all I want. I didn't want to get the last word. Again, you don't necessarily have any knowledge of what I do per se outside of my relation to Dr. Erkman. But and statistics, I'm not a religious person, but I am very spiritual as a surgeon, certainly. And I once heard that statistics are basically, medical statistics, are patients with their names wiped off. What do I mean by that? You don't know. Even if there's a 1% chance, which in your situation is far from that of long-term survival, you don't know what that 1%, who that 1% is going to be. So, and I don't want you to lose sight of that. Just keep on doing what you're doing, because you're doing it right, and there's no right answer necessarily. That's all I wanted to say. Okay?
I'd like to add also that I'm redefining, reapproaching, how I go about this, dealing with this. far as diet. Just getting used to it, the discipline of it, what I need to do. And I really, some foods I don't want to give up, but, I just have to do what I have to do. And this is my second go around with cancer. I was treated 10 years ago for prostate. And cancer has been in my family. I've lost family members to this disease. So that's a little more history on that side of it.
I think Anjali came in the room. Maybe we were just talking. Yeah, we were just talking before. So Anjali's one of our amazing social workers. I've been stressing team approach, but we were talking before about like stress of coming in for your surveillance scans and everything that goes along with that, or just coming into the institution for whatever you're coming in that day to see. And I kind of, or we all echo that this is something that we hear about all the time, and I'm sure you hear about it probably even more than we hear about it. But maybe I don't know. I'm sure you don't have a magic way to fix it, but kind of your impression and what you hear from patients, maybe that would be helpful.
Yeah, like Dr. Farm is saying, we recognize that the anxiety, the fear, the worry, part of the process. And as I had said, initially, I worry more about patients who tell me, there's nothing I'm afraid of, I'm not worried, because I can't imagine going through an experience like this, whether it's you individually going through it or as a caregiver or a support person. There's always some element of worry, fear, stress, all the emotions that you may have experienced at different points in your life, and suddenly you're feeling them in a way that you couldn't imagine experiencing them before. People have said to me, I felt fear before, but never paralyzing fear. Never where I felt like the fear completely took over me or occupied every thought, or I felt like my breathing reflected how fearful or anxious I was. And so oftentimes I think just sort of acknowledging the emotion takes a little bit of the power away, because I think often, people will say to me, I try to ignore it. But we use the analogy of it's sort of like having a pink elephant in the room where everybody's sort of ignoring the presence of the elephant, but we know it's there. And so it starts to get bigger and bigger and bigger because the presence needs to be felt. It needs to be acknowledged. And so sometimes just saying, you know what, I am whatever, scared, worried, feared, sad, angry, whatever the emotion is, filling the blank. Because once you put a name with the emotion, sometimes it helps reduce the power or the feeling that that emotion has over you because you've given it a name. I have a patient that I see for counseling, and I've been seeing her for years. And she said to me she gave her anxiety a name because she felt like just saying, I feel worried, couldn't really encompass it. So she named it Ashley. So she's like, Ashley's coming with me. Ashley's doing this. And it became kind of a joke. But it was one of those ways where she coped with her anxiety by giving her a name. And she'll say to her, Ashley, cut it out. Like, Ashley, and we laugh about it, but I find that it helps her so much because she's taken something that she felt controlled her, and now she's put herself back in control because she's telling her, no, you don't get to do this right now. I know you're there, you're annoying me, but I'm not dealing with you today. And sometimes just doing that or knowing that it's okay to do that helps. And of course, my role is to be the support person, so I always encourage everyone, even if you don't know what it is you're feeling or what it is you want to talk about, it's okay to say that. It's okay to say, I don't know how I feel, or I couldn't tell you what thought is going through my head right now, but I just want to sit here and I want somebody to listen and I don't want you to say a word, and that's okay. So please know that you can always talk, even if it's just to pick up the phone and say, I don't even know why I called you, but I felt like I should. It's okay. Sometimes even just sitting there for a couple minutes and not saying anything is saying something.
Anjali, don't the social work department, just like our physicians, specialize, work on, we call them service lines, but Anjali works with the GI group. There's another social worker who just works with lung cancer. So all of the specific needs that you have because of your cancer type, that is just another benefit of the social workers because they understand it more than the average person.
So yes, to Lisa's point, the way we're all divided up by service line. For GI, there's actually 4 of us. But like I also see all the sarcoma patients and all the melanoma patients. And one of the things I love about this model is that I not only have an understanding of the disease, but also the treatment. So that when someone says to me, I'm on this particular drug and I'm feeling nauseous, I have an idea of, you know, is this nausea something that's just going to be here for a couple days? Is this something that's going to be there every time they get treatment? Or, you know, I'm going to be having this particular surgery. Well, I understand sort of what the I mean, not to the extent that surgeons do, but I understand, okay, the healing time might look like this. These might be resources that they'll need at home after the surgery's done, just because we've seen patients with that type of surgery or chemo or whatever the intervention is. So there is a benefit to that. Plus, we get to work very closely with the doctors that you all see, and we get to be part of that team, which is pretty amazing as well.
Thank you, Angela. Sometimes I feel I need to give you a call myself. I don't know why, but I just feel like.
Are there any other questions, or kind of getting towards the end? Yeah. Great. Okay. They asked me to just, you know, so we appreciate everyone coming tonight. This program has been recorded and it will be uploaded to our webpage on YouTube. You can check out our website for upcoming patient programs. On July 1st is our annual Survivor celebration, and so that's usually a big event, and details will be emailed out. It says good night and take care. I would just emphasize, you know, if you have friends, family, number one, everyone should get screened for cancer. So if you have friends, colleagues, anyone, please encourage them, because we want to identify cancers early. 2, if there's anyone, God forbid, ever that needs to be seen here, you can reach out to any of us at any point, if it's our expertise or not, just to get people in. We all want to just, our goal is to have everyone be able to get the best possible care. And if there's someone that you think needs to be seen here, for whatever it is, you can always reach out to any of us. So thank you all for coming tonight.